Good morning, everybody. Happy Thursday. Let's kick it off by thanking the people who are making this happen today, starting off with Simi, who's scribing. Hi, Simi.
Hello, everyone. Hello, Rabih, and I'm very excited for today's session and Sarah's case and discussion by Rabih and Hee Mun. So looking forward to it.
Simi, what has been the highlight of your day so far?
Rabih, the highlight of my day is that I'm fasting and it's almost iftar time in 20 minutes, and
Yes.
I'll be iftar with you all. Looking forward to my semester.
What do you have planned? What's the first bite today? Do you know?
I'll have a date and samosa and lots of, juice.
Amazing. That sounds delicious. What about you, Zachariah? What are you up to?
So hi everyone. So with it being Ramadan and me having reverse day and night, it's basically like 3 o'clock in the morning for me, even though it's technically 3 p.m. So a little bit sleepy, but I'm sure this will wake me up.
What has been the highlight of your day so far, or your night so far, I should say?
We're getting in like for the first time in a long time, 8 consecutive hours of sleep without waking up, which is good.
Wow. The privilege of sleep, we take it for granted. I met a patient who was paralyzed with insomnia, and the way he was telling the story made me just like made my soul crush, just how hard it was to exist with very little sleep for him. So I'm glad you got 8 continuous hours of sleep, and I certainly don't think you'll be sleeping for a single second during Human's discussion. I'm very, very excited to share that she will be in the lukewarm seat today. And Heman and I have actually shared a discussion before. So I've shared with you all her journey through CP solvers and yada yada, all that stuff. But in the last few months, really gotten to know her much, much, much better. We spent a lot of time on the phone. God, maybe like 3, 4 months ago, where her vulnerability to her growth and what she wanted to accomplish and do was just so eye-opening. And I think I really admire just how dedicated she is to becoming the best version of her clinical self. If Hemo's not on VMR, you probably have to wonder and worry about her medical safety for a moment there, because she's literally here every single day. And I think nothing else really captures just how dedicated she is to this space. And so no better way to honor that than to discuss. Hemon, what time did you wake up today?
Yes, I woke up at 3 a.m. I was very little bit excited and nervous. Yeah, this time I did not match, but the support that I received from the CP server family has been really amazing, and I'm really grateful for what they gave me. And I think there's so much room for growth. I mean, even today, I think I can learn so much from my great teacher, Robbie. So just moving forward and not giving up, I think that's my goal.
Oh my gosh, Himun, I've been doing this for too many years now. I notice I'm starting to have a lot of white hair. Although by cutting it very short, I hide it from you all very well. Um, and yeah, Hans is squinting like I don't see any white hair. It's there, Hans, I promise. Um, but I'm learning every single day, every single case. And I think that journey is literally endless. And today we're very lucky to have a guest presenter who is going to share this journey with us. And I'd love to hand the mic to you, Sarah. Just tell us a little bit about yourself.
Yeah, hi. My name is Sarah. I'm a fourth year medical student at Emory University. I'm currently taking a master's year. I was introduced to clinical problem solvers through just word of mouth. People talking about it at Emory. It's kind of a fan club here, I think. Um, and then as far as things that I do in my free time, like fun stuff, I like to go rock climbing, and I also like to play guitar. So again, excited to be here. Really grateful for the opportunity to present.
We're thrilled to have you. Sarah and I were talking behind the scenes with the CP Solvers team members about your journey initially towards internal medicine, and a little twist towards neurology. And I will tell you that even though we mostly have internal medicine cases, the a very close second is neurology, and so we have some neuro enthusiasts in our team, and some of whom are here today. So I hope that your case will have a little theme of what you love the most, but if it's shy from that, we'll also have a great time. So Simi, feel free to share the whiteboard, and Sarah, we can rock and roll whenever you're ready.
All right. When the whiteboard is up, I'll get to presenting the first aliquot. The first aliquot is just the chief concern. So I'll start there. 41-year-old male with abdominal pain and diarrhea.
I love the stopping at the chief concern. Thank you, Sarah. So Hee Mun, you only have this to work with. What are you thinking?
Okay, so we have abdominal pain with the diarrhea, and I just want to see like the onset is very important. And for the diarrhea, so I always think about gastritis, like a food related. So whether a person had a travel like area, and also like typhoid fever, could cause the abdominal pain and diarrhea. So, and also the person who's having this abdominal pain and diarrhea, I would like to know the past medical history, whether this person is having any like immunocompromised, HIV, and or all others issues, and also and I have to check the abdominal pain, very important VIPO, like vascular ischemia, and also inflammation and infections, and also perforations and obstructions. And so like infection could be like the also pancreatitis. And also I'd like to know the person's diabetic. Always DKA and HSS can cause a lot of abdominal pain. And also I want to know the hypercalcemia can cause abdominal pain. So like hypercalcemia, and also other endocrine adrenal insufficiency or TSH, hypothyroidism, all those things I have to concern about it.
Oh my gosh, you're thinking about so many things, Hee Mun. I love that. I'm curious. So you started on you seem to focus much more on the abdominal pain. Do you mind explaining why you're focusing more on abdominal pain and less on diarrhea?
I think the abdominal pain is like because diarrhea can be the result of abdominal pain. I think the source of abdominal pain is more important, and yeah, I think that's why.
Yeah, I think that's true. I think most of the time, whenever you have somebody who has two things together, I think the more morbid possibility should be the center of your attention. And so if somebody has abdominal pain and diarrhea, you ask yourself, what kinds of emergencies can live under diarrhea and what kinds of emergencies can live under abdominal pain? And I think you'll find that there are way more emergencies, vascular, infectious, perforation, obstruction, under the world of abdominal pain for sure. And so when you try to analyze them separately, you realize that most of your attention will be towards the abdominal pain. But I think a key question is, well, most patients with abdominal pain don't have diarrhea, and most people with diarrhea don't report prominent abdominal pain. So it becomes a question about what it means that the patient is saying both together. So, Hee Mun, I'm really curious. If this patient has both those things, what does that signify to you?
Just a moment. Yes, I think that abdominal pain could be the like a cause of the malabsorption, like or like malabsorption, like celiac disease or like pancreatic insufficiency could cause the diarrhea. And also maybe I don't know about the patient's history, but could be like a IBD could cause. And also infectious cause is most important things to consider, like salmonella, shigella, bacteria, or like virus cause. Can also cause abdominal and
Very good.
diarrhea.
Very good. Very good. Now, all I'm going to try to do is explain why you made that list. And the first thing to help you understand why your list is so accurate is to emphasize that most patients with GI bleeding, i.e., a intrinsic issue in the actual lumen, don't have any pain at all. They just have blood coming out of their GI tract. So issues inside the GI lumen, like bleeding, are completely painless. That's because the inside of the GI lumen is not innervated. In stark contrast, the outside of the GI lumen, the part that is living right in the peritoneum, is richly innervated. And irritation of that aspect causes peritonitis. And so when you're saying, oh, a patient with abdominal pain has diarrhea, you now know that their GI lumen is involved in the syndrome. And so you now ask yourself, well, what layer? Is it the inside or the outside? And most of the time, when you have a lot of diarrhea and just a little bit of pain, it's probably the inside of the GI lumen, like a regular old gastroenteritis. If it's a lot of pain and just a little bit of diarrhea, it's probably the outside. But if the diarrhea and the pain are equally important, then the disease localizes between those two things, the wall of the GI tract. And that's where inflammatory bowel disease lives. That's where invasive infections like salmonella live. And so, as Sarah tells us in more detail, the HPI, we're going to have to make a judgment call about whether we think this is diarrhea predominant, pain predominant, or they're both fighting for predominance. And if they both are competing for it, the odds are that we are on the look for a disease that is affecting the wall of the GI tract. And yeah, I'll leave it at that. We'll take it from there. So your list is spot on. And now hopefully we all understand where that localizes to. Sarah, see, we do some localization in medicine too. And we'll see what we'll see where we land with more information.
Yeah,
All righty. Thank you, Sarah.
I think our HPI is going to be really helpful here. So on to aliquot number 2. 41-year-old male with history of migraines, type 2 diabetes, last A1C of 10.6, who presents with chief complaint of abdominal pain and diarrhea with new acutely worsening headache, blurred vision, and scleral icterus. 1 month ago, Mr. J was experiencing significant stress at work, reporting total of 1 hour's sleep in the last month. He noted around that time he began having watery diarrhea with 10 BMs per day, lower abdominal cramps, and 1 episode of emesis, which was dark red. Diarrhea was worse with food, and pain that radiated to the epigastrium and chest. He also mentions that he'd had 2 episodes of dark red stool in the last week. A few days ago, his coworkers noticed that his eyes were yellowed, and he noticed that his urine was dark. He started experiencing headaches, blurred vision, and shortness of breath around that time. He has not had right upper quadrant pain and denies any pain with swallowing, trouble swallowing, or coffee ground emesis. He denies new rashes, bruises, lymphadenopathy, or trouble balancing. He does admit that he's had chronic knee pain and tinnitus from his time in the military.
Sarah, you're presenting this like an absolute pro. Thank you so much for all that information. Hee Mun, we have a headache. We have shortness of breath. We have abdominal pain. We have diarrhea. We have scleral icterus. We have basically, and we have knee pain. So the truth is, there's not a single part of this person's body that's unfortunately not affected by this. So the question for you is, what do you think is the most helpful place for you to think about all the information you receive?
I think I will go for the jaundice. That patient was having scleral icterus, right? And then, you mentioned about a lot of jaundice, like intrahepatic, posthepatic, and all
All right,
those.
I'm so sorry, Hee Mun. I don't want to interrupt you, but I'm really curious for those people who are more junior to you. Can you explain to them why you chose jaundice? And then you can talk. Well, why did you choose it? Because it's absolutely what I chose also.
Um, yeah, because jaundice can really contain everything. I think this patient is having headache, blurred vision, could be due to the thrombosis, like the portal hypertension can, like caused by jaundice, like intrahepatic or extrahepatic, or, like non-cirrhotic portal hypertension can cause any, like, like a Behçet disease or anything can cause like the thrombosis. That was, like really touching my head, so
Right.
like could be headache and blurred vision. Also, jaundice can be caused by a lot of infection too, right? I mean, EBV, CMV, yeah, EBV, CMV, or TB. Those can also, having a systemic problem. And you mentioned that if liver, like if liver is affected, it can really systemically
Yes.
affecting all those system, right? So yeah, so I think that's why jaundice was very important, because like even like jaundice can ascites. I don't know about this patient is ascites, but shortness of breath could be caused by
Right.
ascites or pleural effusion, or like, so we'll see how it goes.
Right. Hey, Hee Mun, have you ever had a headache before yourself?
All the times.
Yeah.
All the time.
And I can guarantee all of you know that Hee Mun does not have a problem in her head, right? I mean, look at that, right? And I think that what you're fundamentally saying is that a headache doesn't mean there's a problem in a head. Shortness of breath doesn't mean there's a problem in the chest. As you said, it could be ascites compressing the diaphragm. Scleroicterus means a very specific kind of problem. And so the reason that Hee Mun is inclined to use jaundice as her starting point is, of all this, it is the most specific to the underlying disease. Now, we could learn that the headache is very serious later, but most people with headache have no problem in their head. Many people with nausea and diarrhea don't have true intraluminal issues. And so the specificity of scleroicterus is very, very high. So I'll now hand the mic back to you to finish what you were doing about just teaching people how you think about jaundice.
Rabih, but
Yes.
before Sarah started neurology, I was just
Oh, no, I meant to
wondering,
you.
like,
Yeah. No,
oh,
sorry, Hee Mun. I said, can you now, you were going to, and I interrupted you. Can you teach everybody, Hee Mun, how do you think about jaundice? How do you break it down?
okay. So yeah, before I talk about jaundice, can I talk about 1 hour sleep? I thought maybe patient is having like hepatic encephalopathy, like there's a stage 1, 2, 3, like sleep disorder is a stage 1, I think, grade 1 for the hepatic encephalopathy. So maybe because of that could be the cause of the sleep disorder, or maybe toxin, accumulate, could be cause the headache and 1 hour sleep. But anyway, jaundice. So yeah, so jaundice can be indirect and direct, right? Indirect could be caused by the hemolysis of the and then direct will be like, as we know, that cirrhosis, and like it could be like hepatitis, intrahepatic, like extrahepatic can cause. And I would like to know, the patient had a dark urine, right? But how about the stool? Was it like pale stool, or was it okay?
He didn't say that he had any pale stools at the time.
Okay.
And then he also mentioned that he did have that one episode of dark red.
Okay.
Yeah.
Yeah.
I'll
So
tell you, I never ask people about pale stools. You know
yeah.
why? Because I don't care. Because I'm going to
Uh-huh.
get their direct and indirect bilirubin in 1 hour. Why do
Yeah.
I need to rely on the pallor of their stool? So I think it's a good thing for step 1, step 2, and step 3, but for real life, I don't think it's that.
Right. Yes. So I just wanna, like, jaundice, could be like prehepatic, right? Hemolysis and intrahepatic hepatocellular disease, hepatitis and infiltrative disease, and systemic condition like
Right.
amyloidosis, and posthepatic will be obstruction from gallstone structure, malignancy. Those are the things.
And
But
what do you think
mhm.
this patient might have? Are you thinking, first, let me ask you, are you thinking it's more likely to be direct or indirect? How are you using the other information to help you?
I think that it could be direct, because that the person is having a lot of like indirect will be hemolysis, right? Like shortness of breath, or actually this person was having shortness of breath, right?
Yeah.
So could be cause of the hemolysis can cause the systemic symptoms. So I'm not sure. I was thinking direct, like I was thinking about some thrombosis, causing
Yeah,
those. So I
sure.
thought maybe non-cirrhotic portal hypertension, but yeah, I mean, shortness of breath.
It's
What do you think,
hard, right?
Rabih? Yes.
Very hard. This case is very, very difficult. I think you're doing an outstanding job. And as you can see by my questions, I'm trying to get as much brain power out of your excellent knowledge, and you're taking it very far. You said something earlier that I think is very helpful to reemphasize, which is when jaundice is accompanied by systemic disease, it's unlikely for the disease to be in the post-hepatic biliary tree. That's because, with some exceptions, that's because the post-hepatic biliary tree is a simple drainage pipe. And if it's clogged, the patient usually just has isolated jaundice with maybe some pruritus. Though, of course, you can have cholangitis and you can have metastatic disease from that area. But in general, you should start by prioritizing you should start by prioritizing the liver itself in cases of systemic disease with jaundice, as Hee Mun said. But Hee Mun, as I think you realized, somewhere in the back of your mind, you also realized that actually indirect hyperbilirubinemia, like hemolysis, is also associated with systemic disease. So I would say that I would just see this as the following. This is a complicated HPI. It's going to be difficult to figure out where to invest our diagnostic energy and the significance of all these symptoms. And by observing the patient on physical exam, we'll be able to determine how uncomfortable is the headache, how uncomfortable is the shortness of breath, how bad is the knee pain, and be able to triage those things into really bad, unknown, or maybe we can put them aside for a moment. That's what the value of your eyes are. Trained eyes can filter this HPI effortlessly. And so that's what we're going to do. But I think you can start to say, this is a systemic disease with jaundice, not just jaundice full stop. And a systemic disease with jaundice prioritizes indirect hyperbilirubinemia, which has hemolysis, but also some other things that may or may not involve sleep, which we'll talk about later, and the liver itself. And so I'm like you, really paying attention to those things. But why don't we hand the mic to Sarah to give us the next round of information?
That's super insightful. Systemic illness and jaundice, and to include those things in your differential. So moving on to aliquot 3. This will be a medical history and social history allergies. Medical history is significant for hypertension, diabetes, for which he takes PRN metformin when his blood glucose is greater than 150, migraines, and he's not on any therapy for that, and an anal fissure per outside hospital chart. Home medications, just metformin, and then past surgical history, only significant for appendectomy. Family history, a mother with arthritis and a heart attack in her early 70s. She is deceased. Brother with HIV, deceased. Sister, CKD and type 2 diabetes. And then no known family history of autoimmune conditions. Social history, he works at the airport and manages multiple restaurants. Sexual history, he's married and monogamous with total of 2 lifetime sexual partners. The last other partner was greater than 13 years ago. He states he receives regular testing for STIs at his primary care doctor's office. His last HIV 1 month ago was negative. Drugs, no history of injectable drug use, and uses less than 1 drink per week of alcohol. He has no history of blood transfusions or any major motor vehicle crash. And he was previously in the Army, served at Fort Benning in North Carolina, and he has chronic knee pain from jumping out of planes.
Awesome, Sarah. Thank you so much for this rich history. Hee Mun, did this history influence your thinking in any way or not so much?
Not so much, but since he's married and one partner, there's less of hepatitis, and not traveling, right? So not like hepatitis, or like any hemorrhagic, like malaria or like all those is a rule out. So yeah, what do you think?
Same. I think it just goes to show you that when you don't have your finger on what the current problem is, it's hard to know if the past is relevant or not. And it may be that we define a new problem that has no linkage to his past, or we find that after we clarify what his issue is today, something in his past may be very valuable. And so I think if you had painted a picture of somebody whose abdominal pain and diarrhea was more like DKA, if that, then you would be like, oh, I think his diabetes is relevant. Or if he had a prominent alcohol use history, you might say, wow, okay, jaundice plus alcohol makes me think cirrhosis. So I think that the problem is not yet clear. And hopefully, once we clarify it, we should look back and see, was there anything in the history that was relevant? But for now, I'm right there with you. I haven't made any strong attachments yet.
I have a one question. Since he has chronic knee pain, maybe he's
Yeah.
taking acetaminophen, like drug.
Yeah.
Just wondering.
Yeah, very possible. I think that Tylenol toxicity is one of the things to always assess for and think about in somebody who is presenting with jaundice. But Hee Mun, you might not even bother to send a Tylenol level if most of his jaundice is indirect, right? And so if it's direct, then oh my gosh, right away. But if it's indirect, I think you're probably not going to get much return on investment of that test.
True.
Yeah. All right, Sarah, what do you got next?
Okay, this will be exam and initial labs. Vitals, temperature 36.7, heart rate 76, blood pressure 147/97, respiration rate 20, oxygen sat 100%. General appearance, he was laying comfortably in bed in no acute distress. HENT, scleral icterus was present, but he had moist mucous membranes. Cardiovascular, regular rate and rhythm, no murmurs. Pulmonary, clear to auscultation bilaterally with symmetric chest rise, no obvious rhonchi. And then abdominal exam. Abdominal exam, soft, non-distended, no guarding, no rebound tenderness. Liver, non-tender to palpation. Murphy's sign, negative. Lower quadrants, tender without guarding. Extremities, moving all four extremities with ease. Minor scars on his lower extremities. Neuro, alert and oriented, no confusion, normal affect, congruent with his mood. And then labs, white blood cell count, 3.7, 2% neutrophils, 1.3% lymphocytes, 0.4% monocytes, 0% eosinophils. Hemoglobin of 15.4, MCV of 79, platelets of 180, sodium 138, potassium 3.8, chloride 103, bicarb 26, BUN of 13, creatinine of 1.2, liver function, AST of 1,162, ALT of 1,156, ALP of 223, T-billy of 23.3, D-billy of 17.7, PT of 12.6, INR of 1.2, or 1.1, sorry, PTT of 30, and urinalysis with uro and billy positive.
Fascinating, Sarah. Thank you so much. This is such a well-presented case. Really giving us a play-by-play on probably how this case was evolving in real time. So Hee Mun, you had some hunches now. How are you updating your problem now? What would you say the problem that you're trying to solve is?
Okay, so like the physical exam was not showing any like cirrhosis, like the gynecomastia or like spider nevi or any abdominal distension, not showing the ascites, right? And also the patient was having fever. I'm just wondering, like temperature was normal.
Yes.
Okay. All right. So not really showing the cirrhosis, and also the person is having WBC 3.7, right? And hemoglobin is high, and platelet is normal, and but the AST ALT is really elevated with the bilirubin really high. So yeah, so I think it's liver related. Direct bilirubin was really high, right?
Yes.
Yeah. So yeah, so we can rule out the indirect hemolysis. I mean, I'm not sure about LDH and hemoglobin, but we can just rule out the indirect, and then direct we have to focus on what is really causing AST/ALT this high. So usually when AST/ALT is really high, we always think about the ischemia, hepatitis, and autoimmune, and also drug induced, and also like the person could have a like toxin like Wilson disease can also have a high elevation. And also bilirubin is really high, but alkaline phosphatase, this is high or is it normal?
It's a little high, but
It's
not very,
okay.
very high. Yeah.
All right. So we can even think about like extrahepatic, right? So patient are having so much like the abdominal pain and systemic symptoms. So maybe cholangitis. We have to always think about cholangitis always in our mind. So yeah, that could be another reason. And also maybe another like liver abscess or
Mm.
yeah, I mean cholangitis could be person didn't have a hypertension, right? Like the
Mm.
yeah, so yeah, those are my thinking. But how about you?
Yeah, I'm really curious. You asked for the direct bilirubin. Now you know it's direct. And so you said before it's either intrahepatic or posthepatic. So what do you think now? Do you think it's intrahepatic or posthepatic? What do you think?
I think it could be both. I mean, like, because ACLT could not be this high elevated in, like post-hepatic,
Yeah,
right? So
exactly. Why did you say
intrahepatic,
both?
because choline phosphatase and direct bilirubin was really high, so I thought maybe possible. But I think intrahepatic with the infiltrative disease can cause this much.
I think if you start with the jaundice and you remember that um, the bilirubin is excreted in the extrahepatic tree, but
Mm-hmm.
the small bile duct cells go into the liver itself. And so a direct bilirubin alone does not help you localize between intra or extrahepatic because the microscopic bile ducts are in the liver themselves. So if you just look at it from the presence of the bili, you cannot distinguish if the disease is in the big ducts or the small ducts. However, the big ducts don't have any AST or ALT in them at all. And so when you see that there's this amount of AST and ALT, you know that the hepatocytes are being destroyed and lysed. So you then conclude that it is impossible for this disease to be only in the extrahepatic biliary tree because there is no AST or ALT in those cells whatsoever. There's one exception to that rule, but that's not worth our time today. And so now you know the disease is in the liver. And as you said, the question is it disease of the liver hepatocytes, like acute hepatitis? Is it a disease of the intrahepatic bile duct cells like primary biliary cholangitis? Or is it a disease that lives in the interstitium between those two cells? And you can make a lot of progress to localizing it to the liver cells because of the magnitude of the AST-ALT elevation. So I would say with a high degree of confidence that this patient is having subacute hepatocellular injury, and that there is something that is causing his hepatocytes to die. And how do we know it's subacute? It's because, of course, he's saying it's subacute, but in order for your bilirubin to become 23, the disease needs to evolve over at least a week. And that's why ischemic hepatitis and some other less common considerations are unlikely because they don't evolve over that period of time. You'll find that patients with ischemic hepatitis have super high AST-ALT, but their bilirubin is not 23. So you can literally localize this to a microscopic location of subacute hepatocellular injury. So yeah, I think Hee Mun, that's the localization I'm doing. And so I'm curious, what are the most common causes of acute hepatocellular injury that you know of?
I think the drug induced and
Yeah.
also the hepatitis, right?
Excellent. So it would be premature to go beyond those two things as your first pass workup. And that's, you would send off a viral hepatitis panel, and you would screen the medication list and herbal supplements list, and as you suspected, get a Tylenol level in this patient.
Can we do the
Now,
autoimmune too?
I don't know. I think you have to be conscious of the fact that you're going to have many of these patients, an autoimmune hepatitis, malignancy-related hepatitis, metabolic causes of acute liver injury like copper overload are really rare. And
Mm.
so do you test every single person who has these conditions for them? I think the answer is no. So who do you test? You test people for whom the viral hepatitis and the drug category is either negative or uncertain, and people who are very, very sick. So if somebody is in fulminant liver failure, there's no time for diagnostic elegance. You do a very broad workup from the get-go. But there are so many patients with this problem that if you do all the diagnostic tests on every one of them, you're probably going to be very, very costly and inefficient. So let me show you a picture of how this is typically done. You think, okay, is there, as you said, a problem with ischemia or post-hepatic? And for reasons we already talked about, the bilirubin is too high for it to be pre-hepatic or post-hepatic. So infection and toxin will be the focus of our evaluation. And if we don't find anything, or if we deem this patient too sick for us to wait, we proceed down this pathway. Okay. I just wanted to call something out that you said. You mentioned, could this be a liver abscess? And I think, or could this be cholangitis? And I think those are very important things for a future intern to worry about every single time. But as a PGY 1 bajillion or whatever now, I'll tell you that those things are very unlikely. Why? AST-ALT is an intrahepatic disease, so cholangitis is less likely. And the beauty of what you can say with AST-ALT this high is this is very likely a diffuse intrahepatic disease. It's causing so many liver cells to die. So if you can imagine a liver abscess as big as the entire liver, which is possible, it's called emphysematous hepatitis. The patient's usually very, 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 very sick. So the sheer magnitude of the AST, ALT elevation suggests that every single hepatocyte is at risk of dying, which if from a liver abscess usually makes the patient very, very sick. So I think, we talked a lot, but I think the simple next steps are to do exactly what you said, to get viral hepatitis testing, to do a toxin review, and potentially to do a right upper quadrant ultrasound for reasons that maybe we can skip over now just for the sake of time. So Sarah, why don't I hand you the mic and see what you have next?
Okay, great. So this will be some additional labs. His C. diff PCR was negative. Stool culture was negative. Troponins were negative. Lipase was within normal limits. He had an LDH of 542. His iron studies were within normal limits. Chest X-ray was clear. His CT abdominal pelvis with contrast showed no acute abnormalities, moderate stool burden, and distended bladder. His right upper quadrant ultrasound, patent vasculature, normal hepatic morphology. And I think iron studies, I said weren't within normal limits, but I believe he also had a high ferritin.
Awesome. Thank you, Sarah. So Hee Mun, what happened there?
Wow, it's very interesting. Yeah, ferritin high. Whenever ferritin is high, I always think of my HLH. So right, and the LDH is 542, huh? Do we have haptoglobin for that?
I think that's in the next aliquot.
Okay. Well, I don't know whether it's a hemolysis is causing this. Yeah, and if it's ferritin high, but iron study was normal, so we always think about like something, yeah, inflammation, right? So I think that's all I can. But then
Yeah.
right upper quadrant was not really showing abnormality, right?
Yeah.
So
Uh,
yeah.
yeah, Hee Mun, I think that Sarah is giving us a really fun things to talk about. But my opinion is that she's just trying to distract you right now. And let me
Okay.
let me explain why. Don't fall for the trap.
Okay.
So
Sarah, you're so good at it.
so where does the ferritin come from? Do you know where ferritin comes from, Hee Mun? Where is it synthesized? Do you know?
Is it liver?
Yeah, and look at this liver. It's so angry. So
Okay.
the value of ferritin in cases is when it's very high and the liver is okay. Then you're like, whoa, why is the ferritin so high and the liver okay? Then it's a diagnostically helpful test. But when the liver is so angry, the ferritin's going to be high. If the ferritin was low, I would be like, maybe the AST, ALT were reported on a completely different patient by accident. So it's not surprising at all that this patient's ferritin is high. It's just an expected consequence. So I think, yeah. And I think the same is for the LDH. So how can the liver release so much ALT and AST into the body without releasing LDH? Because as you said, LDH is an intracellular enzyme found in every single cell in our body. So if you get an LDH in a patient who has rhabdomyolysis with a high CPK, it's going to be high. If you get a patient with liver injury and a high LDH, it's going to be high. The value of an LDH is when you don't know where it's coming from. The CK is normal, the liver is normal, and then you're like, ooh, is it from hemolysis or is it from cancer? But when you have the liver just LDH and ferritin are coming along with those AST and ALT. So that's all smoke. We now have to duck and walk past it and say, nice try, but we're not fooled. So for all of you learning these tests, just know they're very helpful tests, the ferritin and the LDH, but they're only helpful when you cannot tag them with something very quickly. If you can tag an LDH with liver or CK, it's useless. If you can tag a ferritin with liver, it's useless. Now, a high ferritin with normal liver enzymes, very, very interesting, but not the case today, unfortunately.
Good to know, Rabih.
Yeah, for sure. So let's go back to that category you mentioned, infection and toxin, right? We have got nothing to disprove that hypothesis. So when you think infection, what kinds of infections do you think can cause this picture?
Well, I think that hepatitis, right? The
Yeah, excellent.
hepatitis group. I mean, since the person is having hepatitis, there are a lot of hepatitis E and, like a lot A, hepatitis A can cause the abdominal pain too. So like,
Sure.
yeah, we can, and then drug still, we have to know the drug, right? At the
Yeah,
acetaminophen level.
absolutely.
And is it
100%.
possible, should we give the patient until we do the exam and as still, for
Yeah,
the,
very good question. Very, very good question. I would say that most people would give this patient N-acetylcysteine
Hmm?
for this presentation. Yes. The data is the best in patients who have Tylenol as the cause of their liver injury. Very, very high performance. But yes, I think whenever the liver is injured, N-acetylcysteine has become like giving a patient with pre-renal disease fluids. It's like just ubiquitously given. Uh, but I would say what you just said is really, really key. I think that the way this works out is we send extensive viral hepatitis testing. And I think the most probable hepatitis to cause abdominal pain and diarrhea is hepatitis A by far, and then maybe hepatitis E. But hepatitis E in the United States is pretty rare. It is a different kind of hepatitis E that's zoonotically transmitted, actually. So, yeah, I would be eagerly awaiting the hepatitis tests and having a conversation with the patient about what substances have been entering his body, including herbal supplements. But you can never prove drug-induced liver injury short of a biopsy. You can really suspect it based on what a patient tells you or based on the Tylenol level. You can prove hepatitis with labs. So you proceed by trying to prove hepatitis and suspect drug injury. So Sarah, what did you do next?
I love this conversation. This is great. So we did pursue hepatitis workup, advanced labs and imaging. Hepatitis B surface antigen was negative. Hepatitis B surface antibody was positive. Hepatitis B core antibody was negative. Hepatitis A IgG was negative. Hepatitis C antibody with reflex to RNA quant was positive at 100,000. HIV screening, positive for initial screening, and then it was reflexed to a confirmatory test. RPR was negative. CMV IgG was positive. EBV IgG was also positive. Haptoglobin was low. And CD4 count was 360 with total lymphocytes of 982, CD4% of 37, with a normal range between 34 and 65.
Sarah, you're like a pro. Thank you so much for this very helpful alquat. Hee Mun, I'd love for before you tell us what you think the final diagnosis is, I'm curious if you can teach people because I know you probably have thought about hepatitis B more than I have. I'm curious, how are you analyzing the results of hepatitis B?
So the hepatitis antigen was a negative, right?
Yes, yes,
And hepatitis, the antibody is positive.
yes,
Means that the person was vaccinated or maybe had it like in the past,
yes,
is it?
exactly
And
right.
then
And then how does the
the,
core antibody help you decide between those two possibilities?
the IgM, the
Yeah.
hepatitis called IgM was acute, right? And
Yeah.
IgG is like chronic.
Yes, and the
Yeah.
hepatitis core total was negative. So
Uh-huh.
does that tell you vaccination or previous infection? What does that tell you?
Vaccination.
Beautiful. Beautiful. So good. Okay, so what are you thinking of everything else?
So the person is having the HIV, right? HIV is very dangerous, like can cause everything. And as you know, the CMV and EBV really can cause the hepatitis, so maybe is it CMV IgG positive is significant, Rabih, or is not? No, not.
No, and I think
EBV,
yeah.
uh-huh.
I don't know if you saw it. I just want to make sure you saw it. So the HCV RNA is very positive, 100,000. Hepatitis C.
Hepatitis C is okay. Okay, so hepatitis C was the main cause of this person. Very interesting because we thought the hepatitis A and E, but hepatitis C was yeah. So yeah, is it because of the HIV? Is it highly related with the hepatitis C? I don't know about how does it really related, but hepatitis C can cause a lot of other symptoms. So yeah, highly
Beautiful.
related with other yeah.
Yeah, I think that we have to upload our learning
Mm-hmm.
and update our learning about what the most common cause of acute viral hepatitis is in the United States. We used to think that hepatitis C only causes chronic disease, but in a very powerful study done 4 or 5 years ago at a set of hospitals in Boston, proved that the most common cause of acute liver injury from hepatitis is hepatitis C. And so we didn't do this exercise earlier, but if I had asked you very simply, Hee Mun, what is the most common cause of acute infectious hepatitis in the United States? Hepatitis C virus. So base rate would favor hep C. But I didn't want to ruin the learning for all of you before, but I think now is a good time to ask yourselves, could we have suspected hepatitis C earlier, beyond just the base rate? And the answer is yes. So Hee Mun, you mentioned the leukopenia, right? So
Yes.
what would you say are the most important tests to get in a patient with leukopenia?
Mm, um,
Look what Mark said in the chat. Do you see it?
HIV test.
HIV, 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 100%.
Thank
So
you, Mark.
if you're trying to be as shrewd as possible with getting as much juice out of your labs, you would say acute liver injury, infection, toxin. Leukopenia equals HIV until proven otherwise. How does HIV live in the world of acute liver injury? Not directly, but indirectly through co-transmission of hepatitis C, more so than hepatitis B. So these labs, just if you delete, see if Simi didn't scribe at all today and just put the CBC and the LFTs, that's HIV with hepatitis C co-transmission until proven otherwise. Now, of course, you have to finish the workup in this patient. You have to get the Hep A IgM to make sure this isn't also hepatitis A. But I want you all to upload acute liver injury, infection, drugs. Look for other clues. And if you see leukopenia, cone transmission of HIV and hepatitis C is a very, very important thought and not a rare thought because HCV is the most common cause of acute viral hepatitis in the United States. So yeah, I'll leave it at that. I'm curious if you have any other thoughts, Hee Mun, you want to share or questions that you have before we hear from Sarah.
Yeah, it's very interesting because the hepatitis C, I
Mm-hmm.
thought it was asymptomatic usually, not
Right.
like this much.
Right.
Yeah, so very interesting to know. And then HIV and leukopenia,
Right.
like it was really good to know. Yeah.
Yeah, I'll just share with you, Hee Mun, that I also had that teaching that you just shared until 3 or 4 years ago when I learned from Tony Brew that my illness script for hepatitis C was wrong and that many people present like this. It's true, you're more likely to present with chronic disease than acute disease, but hepatitis C is so common that even the smaller fraction of acute disease is still a large number of people. And one thing I will share is that it is more likely for you to develop acute manifestations of hepatitis C if you're immunosuppressed, like this person with HIV. But there's some good news. A decent fraction of patients who manifest acutely with hepatitis C spontaneously clear their virus. So the rate of winning your battle against hepatitis C spontaneously is higher if you develop symptoms than it is if you don't. That's less important now with how good our treatments for hepatitis C are. But before, say 10 years ago, if you were to choose to become symptomatic or not symptomatic from hepatitis C, you would choose to become symptomatic to suffer some period of time, but to have a much higher chance of not living with the disease forever. But anyway, I've spoken a lot. Let's hand the mic to Sarah to see what you have left for us.
Okay, great. Next, aliquot advanced labs again. He underwent a autoimmune workup for hepatitis. Mitochondrial antibody was negative, ANA was negative, smooth muscle antibody was positive at 1 to 40. VZV was negative, and HSV was negative.
Oh, awesome, Sarah. Why don't you take us to the end for just for the sake of time, because we babbled too. By we, I mean me, babbled
Sure.
too much.
Sure. So his final diagnosis, 41-year-old male with history of type 2 diabetes and migraines who presented with abdominal pain and scleral icterus and was found to have acute hepatitis, most likely secondary to new diagnoses of HCV and HIV. Presentation was most consistent with viral hepatitis. Labs later showed those negative autoimmune workup, and the ferritin was most likely reactive. Patient was started on Biktarvy and referred for outpatient ID follow-up for his HIV and HCV, at which time his liver enzymes normalized. And we do have a quick teaching point about HCV. So the peak ALT and AST for acute hepatitis C can often be lower than for hepatitis A and hepatitis B, with like hepatitis A and hepatitis B being over 3,000 in a lot of cases. You can have much lower liver enzymes in hepatitis C.
That's awesome. I don't actually, now that you say that, I think that's been my experience, although I don't think I've uploaded that observation. Sarah, did you happen to take care of this patient, or were you a consultant, or what was your interaction with this learning?
Yeah, I was on the ID consult
I
team at the
see.
time. And I think Yusuf's team was the primary team. So we collaborated.
Amazing. Yeah,
Yeah.
I'm curious, before we hear from Hee Mun, I'm curious, what did you learn from this case in real time? What did you want to re-emphasize for us today? Oh, to you, Sarah. Yeah, what did you learn in real time? What did you want to re-emphasize to us? Yeah.
Ah,
Yeah.
I think for me,
Yeah.
just hearing the kind of discussion about first when you have three things, diarrhea, abdominal pain, trying to decide whether you have a unifying diagnosis that explains all of the symptoms or, two or three separate diagnoses that may be more congruent with what the patient is experiencing. And then I really like that the talk about ruling out any acute, really dangerous causes of abdominal pain. And then, yeah, I think it was just a really wonderful discussion. So
We're so glad you had a good time, and we hope to hear many, many more of your cases in the future. They'll probably start to have a neuro flavor to them, I can imagine, and we'd be very, very grateful for your time. Yusuf, I'd love to hand the mic to you. I know you were involved in this patient's care. Anything that you wanted to emphasize for us, learning that you got from this case?
I think routine HIV screening, like you mentioned, and it was also a lot of counseling spent at the bedside. It was a really beautiful discussion with the patient. I was with the ID attending when they disclosed the diagnosis, and the attending was normalized the diagnosis, oh, this is just a new diagnosis for you. You'll just take a pill a day, and otherwise your life will be the same and won't change. So I think that was a really nice touch for me as well.
Yeah, that's awesome. Thank you for emphasizing the very human element of this case. Thank you. So Hee Mun, what did you learn?
Sarah, I really thank you. I learned so much from your case, and you present so well. And Rabih, as always, thank you so much for teaching. I learned tons of things from this case, as always. Yeah, so really had a good time, and hope to have another discussion with you, Rabih. Thank you so much.
Absolutely. Absolutely. Can I ask you for one favor? Because I think people really enjoy learning from you. What is the one thing that was new to you that you learned today that you want others to also really emphasize? Just
Yeah,
one.
as Mark mentioned, the HIV
Yeah.
leukopenia.
Leukopenia, HIV. That's a really good one.
Yeah, with this, yeah, that was a big lesson. Yeah.
100%. Alrighty, for maybe a more comprehensive view of all the lessons, I'll hand the mic to you, Zakaria.
Hi, what an amazing case. Hee Mun did incredibly well. I'm going to try and keep it short and sweet. Rabih and Hee Mun first discussed a patient with abdominal complaints, and Rabih reminded us that usually we should first prioritize the more morbid complaint, being abdominal pain, but how the combination of the two can actually really help you localize what the disease is. Because with the lumen, that is not innervated. So intraluminal pathologies will usually be painless, whereas extraluminal diseases are richly innervated by the peritoneum and will thus cause quite painful disease. However, when you have a mix of the two, you really should look at the wall with diseases like IBD or invasive infections live, as that can cause sort of a mixed picture with both equal amounts of pain and diarrhea. We then considered jaundice, and the first thing you do when you see somebody with jaundice is to consider those life-threatening causes, being acute liver failure, acute ascending cholangitis, or severe intravascular hemolysis. Rabih then reminded us that when jaundice is seen in the context of a systemic disease, it really sort of localizes you to the liver itself and less likely the extrahepatic or posthepatic tree. We then went on to an amazing discussion on liver enzymes, where he reminded us that the degree of enzyme elevation not only can help you localize the cause of it, but at exactly where the pathology is, because those big hepatic ducts do not have much AST and ALT. And when you start to see AST or ALT enzymes in the thousands, it really tells you that either the small hepatocytes or the small bile ducts next to them are affected, and less likely, but still possible, being the interstitium between the two. We then discussed the causes of marked liver enzyme elevations, and almost always it will be viral, toxins, and ischemic hepatitis. And only after that, you then go down the route of the rarer causes. He also reminded us that some of the other enzymes like ferritin and LDH are often noisy in the context of an acute liver injury and usually are not specific for some sort of other diagnosis. We then went on to our second case of acute hepatitis C in the last 3 or 4 months, where we have to actually update our illness script, as it is now the most common cause of acute hepatitis in the United States. And Sarah taught us that the pearl is that it usually does not cause as high a degree of enzyme elevation as will acute hep A or acute hep B. Usually hepatitis C that presents acutely is seen in middle-aged patients with an immunocompromising condition like diabetes, and it often has a relatively good prognosis with the resolution on its own. Lastly, I learned about a new mini illness script with emphysematous hepatitis being a disease that exists, seen in immunocompromised patients, usually with severe diabetes, and having a really bad prognosis, just like emphysematous cholangitis, emphysematous pyelonephritis as well. So thank you. That was an amazing discussion, and looking forward to tomorrow.
I love the delta between what you have written and what you said. And I think sometimes it can be overwhelming to have so much text, but you have all the core aspects of what you learned, and your narration of them is nothing short of poetic. That was awesome. I also like the idea of a mini illness script concept of something new you learned at the bottom of a new disease. That was really cool. That was a real treat. Simi, thank you so much for scribing in the middle of breaking your fast. Really appreciate it. And Hee Mun, outstanding discussion as always. And Sarah, really appreciate you bringing such a rich case and presenting it so effortlessly for us. We had a great time. See you guys later. Bye.